Welcome to the Deep Dive. We're the podcast where we take stacks of dense information, really sift through all the noise, and pull out the crucial bits of knowledge, the surprising insights, so you don't have to wade through it all yourself.
That's the plan.
Today, we're diving into something that affects millions, truly millions of lives every year, but it's still often, well, quite misunderstood: concussions. We tend to think of them, don't we, as just a bump on the head. But the reality is it's far more complex than that.
Absolutely.
I mean, did you know, for instance, that just in the U.S., somewhere between 1.6 and 3.8 million sports-related concussions get reported each year?
It's a staggering figure.
And that's just sports. If you look at Ontario, in Canada, between 2008 and 2016, over 1% of the entire population got a formal concussion diagnosis each year.
And the key point there is formal diagnosis. Experts are pretty convinced those numbers significantly underestimate how common they actually are.
So it's almost like a hidden epidemic of the brain, and it goes way beyond just athletes on a pitch.
That's a really crucial point to start with, because the common idea, the one you see in films or hear in general chat, is that most people who get a concussion, they'll just sort of shake it off.
Right, back to normal in a few days.
Exactly. Back to baseline within days, maybe a couple of weeks. But as we'll unpack in this deep dive, that's not the whole story, not by a long shot.
Okay.
A significant number of people, probably far more than we generally realize, go on to experience what we call persisting post-concussion symptoms.
Yeah.
Or PPCS.
PPCS.
And these aren't just, minor headaches that linger.
Yeah.
We're talking about a profound disruption to someone's life. Symptoms can last for months, sometimes even years. It can fundamentally change how they function day to day, their well-being. It's serious.
Okay, so that's our mission for this deep dive then, to get past those surface-level ideas and really unpack the nuances. How do we, whether we're healthcare professionals, coaches, parents, or just trying to be informed, how do we spot who might be at higher risk for this prolonged recovery?
And what does the latest research, the really cutting-edge stuff, tell us about how to manage this condition? Because it is pervasive.
Right. So we're going to draw on quite a range of sources: comprehensive medical overviews, some fascinating new scientific studies coming out of Canada, and established sports medicine guidelines.
We'll sift through it all.
Exactly. The goal for you listening is to get a rapid but really thorough grasp of this, hopefully spark some aha moments, and move past the common assumptions to a genuinely well-informed view on concussions and this whole post-concussion syndrome picture.
Okay, so precisely. It's not typically a structural injury you can see on a CT or MRI. It's about how the brain is working. And importantly, it's a specific type of mild traumatic brain injury, or mTBI.
Ah, okay. So people use those terms interchangeably, mTBI and concussion, but they're not quite the same.
Not technically, no. A concussion is really a subset of mTBI. mTBI is the broader category, which might include injuries with more structural changes. A concussion, by definition, implies this temporary functional disruption.
Got it. And the symptoms can vary quite a lot, can't they?
Hugely. From things that are very subtle, maybe just feeling a bit off or foggy, to more obvious periods of confusion or even brief loss of consciousness, there's a whole spectrum.
And that timeline you mentioned earlier about how long symptoms last, that seems absolutely critical here.
It really is. It helps us categorize things. So we often talk about an acute concussion if the symptoms resolve fairly quickly.
Which is typically how long?
Generally within about 14 days, 2 weeks or so. But when those symptoms stubbornly stick around for 90 days or more, 3 months, that's when we start talking about prolonged post-concussion symptoms, or PPCS.
90 days. That's the benchmark.
It's a common one, yes. Although it's worth noting, you sometimes see slightly different timelines in the literature, particularly for sports concussions, where persistent symptoms might be defined as lasting longer than 4 weeks.
Right. But that distinction between acute and prolonged, that's really important, isn't it, for how you manage it?
Absolutely vital. Because the approach to care, the kind of resources someone needs, their likely prognosis, it all shifts quite dramatically once symptoms go beyond that initial acute phase.
And managing this, especially the prolonged cases, it's not a one-person job, is it?
Definitely not. Effective concussion care, particularly for PPCS, is inherently interprofessional. It really does take a village.
Who's typically involved?
Oh, a whole range. Physicians, of course, but also physiotherapists, neuropsychologists are key, occupational therapists, sometimes speech and language therapists, social workers. It's a team effort because the concussion can impact so many different parts of a person's life: physical, cognitive, emotional, social.
Okay, that makes sense. So you mentioned some surprising research.
Yes, this is where it gets really interesting. As we unpack some of the latest findings, especially from a big observational study done right here in Ontario, you might find some of the results, well, quite counterintuitive, actually.
How so?
Well, we're going to challenge some perhaps deeply held assumptions about who's most at risk for that prolonged recovery. For instance, some factors that we've traditionally thought were strong predictors for persistent symptoms.
Right.
They might not hold up quite as strongly when you directly compare people with acute symptoms versus those with prolonged ones.
Really?
And conversely, other factors, maybe things that haven't been discussed as much, seem to emerge as surprisingly significant. It could really shift our understanding of who's vulnerable and why.
Okay, I'm intrigued now. So we'll get into the nuts and bolts of that study.
We will. We'll explore the underlying pathophysiology, too, what's actually happening in the brain, the
Right.
metabolic changes, the structural shifts at a cellular level after the injury, and how knowing that is guiding new approaches.
And then the practical side, evaluation diagnosis.
Exactly. How do we effectively evaluate and diagnose concussion? What does a structured, evidence-based recovery plan look like, including that crucial graduated return-to-play protocol that's so vital for athletes? But the principles apply more broadly, too.
Okay, brilliant. It sounds like this conversation might genuinely shift how we think about brain injury and recovery. Let's dive in. Tell us about this Ontario study.
Right, so this study is titled Characterizing the Profiles of Patients with Acute Concussion versus Prolonged Post-Concussion Symptoms. It was an observational study done across multiple sites.
Part of a bigger project?
Yes, part of a larger initiative called Connecting. And they collected really rich patient-reported data from 7 different concussion clinics right across Ontario.
And what's powerful about that multi-site approach?
Well, it gives great diversity. They included clinics that focused on sports, others on acute care, and some tertiary care centers. So it wasn't just looking at, say, elite athletes or people only in central Toronto.
Ah, so a real mix, geographically diverse too.
Exactly. That geographical and functional mix is a real strength. It gives us a much broader, more generalizable picture of concussion in the real world, not just in specific pockets. A much more comprehensive view of who's getting concussions across different settings.
Makes sense. And how did they gather the information?
They were very thorough. They collected a standardized set of data points from everyone, usually at their first clinic visit or within about 2 weeks of it.
And who was included?
Patients aged 16 or older who had a clinical diagnosis of concussion that lined up with the Berlin Consensus Statement from 2017. It's basically the gold standard internationally for a diagnosis. And they had to be able to give informed consent, obviously.
Were there people they specifically excluded?
Yes, and that's important for understanding the focus. They wanted to look specifically at what we'd clinically call a concussion. So anyone with abnormalities on CT or MRI scans, anyone needing neurosurgery, or those with really complex multiple injuries were out.
Okay.
Also excluded were people with significant pre-existing neurological or developmental issues, or if the concussion-like symptoms were triggered by something non-traumatic, like a seizure or a migraine.
So they really narrowed it down to isolated, traumatically induced concussions.
Precisely. That rigorous approach meant they could get clear insights into the recovery pathways specifically for concussion, without results being confounded by more severe injuries or other conditions.
And then they split these participants into groups for comparison.
Yes, very cleverly for this analysis. They created 2 distinct groups. First, the acute concussion group people whose symptoms had been around for 14 days or less.
Okay, a quick resolvers.
Exactly. And second, the prolonged post-concussion symptoms group, the PPCS group, where symptoms had persisted for 90 days or more.
That 3-month mark again?
Right. And importantly, to really sharpen the difference between those 2 ends of the spectrum, they deliberately excluded patients who were in the middle.
The subacute phase.
Yes, those with symptoms between 15 and 89 days. Taking them out created a very clear contrast between rapid resolution and genuinely prolonged problems.
Yeah.
It allowed for a much more focused comparison.
Right, that makes methodological sense. What sort of data did they actually collect on these people? It sounds like a lot.
It was incredibly comprehensive. They went way beyond just basic demographics like sex and age. They looked at marital status, education level, geographic region where people lived, ethnicity, even annual household income. So a rich socioeconomic picture.
And injury details.
Absolutely. Not just when the injury happened, but how the mechanism of injury. Now, obviously, how many days had passed since the injury when they were assessed.
What about their medical background?
A deep dive there, too. Any prior concussions, other medical conditions happening at the same time, vascular risk factors, history of chronic pain, any developmental disorders, and critically, they gathered detailed information on any history of mental health disorders and any pre-existing problems with headaches or migraines.
Those are often cited as risk factors, aren't they?
They are indeed. They also looked at healthcare use, how often people had been to A&E, their GP, or seen rehabilitation specialists. It was a truly holistic data set capturing a huge range of potential influences.
And they used standardized tools for assessing symptoms, I assume, to keep things consistent?
Yes, absolutely. They used established measures, for instance, the SCAT-NE5, the Sport Concussion Assessment Tool.
I've heard of that one.
It's widely used. It helps assess 22 common concussion symptoms across different areas: physical, cognitive, emotional, fatigue.
So things like headache, dizziness, feeling foggy, irritability.
Exactly, those kinds of things. They also use the Sheehan Disability Scale.
What does that measure?
That's a really useful tool because it gets at the patient's perception of their disability, how much the symptoms are actually impacting their life, looking at things like days lost from work or school, and also days underproductive, where they might be physically present but just not functioning at their usual capacity.
Ah, okay. So it gives quantifiable measures for what can feel like a very subjective experience for the patient.
Precisely. These tools provide objective data points.
So this brings us to the study's main goal and where you said the surprising findings came in.
Yes, this is where it really challenges some common assumptions. The researchers initially wanted to see if patients in the acute group and the PPCS group differed significantly on 4 specific factors, often flagged as key risk predictors for prolonged symptoms.
Which were?
Sex, having a history of mental health disorders, having a history of headaches or migraines, and having had previous concussions.
Okay, those are the ones you often hear about.
Exactly. And the prevailing wisdom, the sort of statistic often quoted, is that maybe only 10 to 20% of acute concussions go on to become persistent.
Right.
So, based on that, you'd logically predict that these known risk factors, mental health issues, migraines, maybe being female, previous concussions, would be much more common in the PPCS group. They should stand out as clear warning signs.
That makes sense. So what did they actually find? Did those factors show up more in the prolonged group?
Well, this is the kicker. Quite remarkably, and actually contrary to what many would expect, and indeed contrary to the study's own initial hypothesis, they found no statistically significant differences between the acute group and the PPCS group for history of mental health disorders, pre-existing headache, or migraine history, or sex.
No difference at all.
No statistically significant difference. Let me give you the numbers. They're quite striking. In the acute group, 37.3% had a history of mental health disorders. In the PPCS group, 37.9%.
Oh,
Virtually identical.
wow.
And for sex, the acute group was 61.1% female. The PPCS group was 66.3% female. Again, when you analyze the statistics across the whole large group, that difference wasn't significant.
That really is eye-opening because it seems to fly in the face of that idea that these factors single out the 10-20% who will struggle long-term.
It does. It strongly implies that the baseline vulnerability, maybe linked to these factors, might be much more similar across everyone who sustains a concussion, rather than just predisposing a small minority to poor outcomes.
So what does that mean practically for a doctor seeing a patient or a coach?
It means you can't just look at someone, see they don't have a history of anxiety or migraines, and assume they're automatically low risk for prolonged symptoms. It suggests we need to perhaps focus more on the injury itself, the immediate symptoms, rather than relying too heavily on these pre-existing conditions as definite predictors of a long recovery versus a short one.
Okay. What about previous concussions? That's almost always mentioned as a big risk factor.
That also showed no significant difference between the two groups in this study.
Really? Why might that be?
Well, the study offers a thoughtful explanation. A history of concussions is a known risk factor, yes, but it's a risk factor not just for developing persistent symptoms after a new injury, but also for sustaining another concussion in the first place.
Ah, I see. So people in both groups might be equally likely to have had prior concussions just by virtue of having had a concussion now.
Exactly. It might be a characteristic shared by many people who seek care for concussion, whether their current symptoms resolve quickly or not. It highlights how tricky it is to interpret risk factors. Are they predicting future problems or just describing the population already affected? It's about the nuance of how these factors operate over time.
Okay, so if those factors, mental health, migraines, sex, prior concussions, weren't the clear dividing lines between the acute and prolonged groups, what did stand out? What did differentiate them? This must be where the study's secondary aim comes in.
Precisely. When they look at the broader demographic and injury profiles, some clear and potentially actionable differences did emerge.
Like what?
Age was a big one. The PPCS group was significantly older, on average, than the acute concussion group.
Much older.
The average age for the acute group was 32. For the PPCS group, it jumped quite substantially to 44.
12 years difference on average.
Yes. And when they looked at age categories, the odds of being in an older age group, particularly 40, 49, 50, 59, and especially 60 plus, were significantly higher for people with PPCS compared to those aged 29 or younger.
How much higher?
Dramatically higher for the oldest group. The odds of someone aged 60 or over being in the PPCS group were over 9.5 times higher than for someone under 30.
9.5 times, that's huge. So middle and older age really seems to be a significant factor for prolonged symptoms.
This study strongly suggests so, yes. It challenges older ideas that maybe age wasn't such a major factor.
Why might older age lead to slower or less complete recovery? Is it biological?
Well, one common theory revolves around something called cognitive reserve.
Like the brain's backup capacity.
Sort of, yes. Think of it as your brain's ability to cope with damage or stress. Maybe its efficiency or flexibility. As we age, that reserve might naturally decrease a bit. So the brain just have less capacity to compensate for an injury and recover as efficiently as a younger brain might.
So it's less resilient to the disruption.
Potentially, yes. While not all previous studies have found such a strong link, this large, real-world comparison in Ontario really points to age, especially being 40 or older, as significantly impacting how recovery unfolds. It also makes you think about how age interacts with other things, like education level, which might influence your cognitive baseline before the injury even happens.
Okay, so age is a major differentiator. What else stood out?
The way the injury happened, the mechanism of injury, that was another critical finding.
How so?
Transportation-related incidents, so car crashes, bike accidents, motorcycle collisions, were significantly more common in the PPCS group. Very much so. The odds of having had a transportation-related injury were 4.5 times higher in the PPCS group compared to the acute group when you compare them against injuries caused by falls or falling objects.
4.5 times. Again, that's a massive difference. Why would being in a crash make prolonged symptoms so much more likely? Is it just the force involved?
That's likely part of it, certainly. The forces in those types of collisions can be greater and more complex. Think about the rapid acceleration and deceleration. That can lead to more widespread sort of shearing forces within the brain tissue.
But is it only physical?
Probably not entirely. There's also the significant psychological stress and emotional trauma that often comes with being in a serious accident.
Post-traumatic stress.
Exactly. We know there's a considerable overlap between symptoms of PTSD and persistent concussion symptoms. And then there's another layer.
That's right.
Litigation. Involvement in insurance claims or legal proceedings, which is pretty common after road traffic accidents, has also been consistently linked with persistent symptoms.
Ah, so it's a complex mix. The physical injury, the psychological impact, maybe even the stress of legal battles.
Precisely. It creates this really complicated interplay that can definitely hinder and prolong the recovery process. It's not just a bang on the head. It's an event with potentially wide-ranging consequences.
That makes a lot of sense. Okay, so we have age and mechanism of injury as clear differentiators. You mentioned geography earlier. Did where people lived show any differences?
Yes, and this pointed towards potential issues around access to care. The geographic data showed that patients in the PPCS group were significantly more likely to live outside of metropolitan Toronto.
Really? In the
Yeah.
surrounding region?
Yes. The odds of living in central Ontario, southwestern Ontario, or other more rural or semi-urban areas were significantly higher, around 4 to 4.5 times higher for patients with PPCS compared to those living right in Toronto.
That's fascinating. What might that be telling us? Is care better in Toronto or is something else going on?
Well, it raises really important questions about equitable access to specialized concussion care. It's possible that while Toronto, being densely populated, might have long waiting lists for specialist care, one study mentioned an average wait of 10 months for tertiary mTBI care there.
10 months. Wow.
Conversely, it could also mean that patients outside the major city center just have fewer options nearby, fewer specialist clinics, less access to that interprofessional expertise needed for complex cases.
So if they can't get the right help quickly enough, the symptoms might just drag on.
That's a plausible hypothesis. A lack of timely, appropriate intervention closer to home could contribute to symptoms becoming prolonged. It really highlights a potential systemic issue. How does location affect concussion care? We need to look deeper into resource allocation across different regions.
Okay, that's a really important system-level point. Now, what about the symptoms themselves? The study used the SCAT-T5. Did the PPCS group just have symptoms for longer, or were the symptoms themselves different or more severe?
They were definitely more severe. While both groups obviously had symptoms, the PPCS group consistently reported significantly higher perceived symptom severity across all the SCAT-T5 domains: the fatigue, emotional, cognitive, and somatic physical symptoms.
So more intense symptoms across the board.
Yes. For example, fatigue symptoms were much more prevalent in the PPCS group, and fatigue often goes hand in hand with emotional symptoms and sleep problems after concussion.
And emotional symptoms like anxiety or irritability.
Those also tend to increase months after the injury
Ah.
in people with prolonged issues, which aligns with what this study found. It suggests a much more pervasive and debilitating cluster of symptoms in those who don't recover quickly.
What about the cognitive ones that brain fog people describe, the trouble concentrating or remembering?
Again, consistent with other research, while cognitive problems often get better relatively quickly in acute cases, maybe within days, they can unfortunately persist for years in some people with PPCS.
That must have a huge impact on daily life, work, study.
Absolutely massive. And similarly, those physical or somatic symptoms like chronic headaches, persistent dizziness, that awful sensitivity to light or noise, they were also significantly more common and severe in the PCS group.
Are any particular symptoms early on seen as predictors?
Yes, reporting a high number of somatic symptoms, especially headaches, right in the acute phase after the injury, is often considered one of the better predictors that symptoms might persist for longer. It shows how all these different symptom types, physical, emotional, cognitive, can weave together into this complex challenge for patients. Makes it really hard to treat sometimes.
It really sounds like getting the right evaluation and management right from the start could make a big difference. Can we talk a bit about the overall approach to assessing and managing concussions? What are the key steps, whether it's an athlete or someone from that car accident?
Yes, absolutely. The foundation, the absolute cornerstone, is a thorough history and physical examination.
What does that involve?
You need every detail about the injury, how it happened, the forces involved. Was there any loss of consciousness, however brief? And critically, any previous injuries. Then, a detailed past medical history is vital.
Checking for those potential influencing factors.
Exactly. Previous headaches, migraines, any history of depression, anxiety, chronic pain, dizziness. These can all shape the recovery path, even if, as the Ontario study showed, they didn't perfectly distinguish the acute from the prolonged group in that comparison.
And the physical exam.
A full neurological assessment, checking cranial nerves, vision, reflexes, muscle strength, proprioception. That's your sense of where your body parts are and sensation. It's about building that complete clinical picture.
For athletes, there's often that immediate sideline check. What's crucial there?
That immediate sideline evaluation is critical in sport. First priority is the primary survey checking, airway, breathing, circulation, the absolute basics. And crucially, looking for any sign of a spinal cord injury.
Neck pain, altered sensation.
Yes. If an athlete's mental state is off, or they complain of neck pain, you must assume a cervical spine injury until it's proven otherwise. Safety first.
Are there immediate red flags that mean straight to hospital?
Definitely. Things like a deteriorating level of consciousness, a really severe headache that keeps getting worse, any new focal neurological deficits like weakness on one side, those warrant immediate emergency transport for urgent brain imaging.
And assuming none of those red flags, what happens next on the sideline?
Then you move to the secondary survey, focusing specifically on cognitive function and those classic concussion symptoms. And the absolute rule here, the non-negotiable, is that any athlete showing any signs or symptoms suggestive of a concussion must be removed from play immediately.
No finishing the half.
Absolutely not. No return to play on the same day. Full stop. Their health is paramount.
Yeah.
Far more important than the game.
And that's where tools like the SCAT-5 come in useful again.
Precisely. The SCAT-5 is designed for that situation.
Yeah.
It's standardized, widely used for athletes age 13. And up, there's a child SCAT-5 for younger ones, too.
What does it involve?
It has components for immediate on-field assessment, looking for visible signs, asking quick memory questions like the Maddox questions, using the Glasgow Coma Scale for consciousness level.
And then off the field?
Yes, ideally in a quiet, private space. There's the standard assessment of concussion, the SAC test checking orientation, memory, concentration. There's also the BSS test, the balance error scoring system to objectively measure balance, which is often affected.
Are there other tools used?
Yes, things like the impact test, which is computer-based. It looks at verbal and visual memory, processing speed, reaction time. Often you compare the athlete's post-injury scores to their own baseline scores taken before the season started.
Ah, having that baseline is helpful.
Very. And the King-Devick test is another one, looking at eye movements and concentration by having the athlete read numbers quickly. These tools give objective data to help the clinician make informed decisions.
So lots of assessment tools. What about brain scans, CTs, MRIs? You said earlier they don't diagnose concussion itself, but when are they needed?
That's a really common point of confusion.
Yeah.
You're right. Generally, advanced imaging like CT or MRI is not needed to diagnose a concussion. Remember, it's primarily functional. Most scans will be normal.
Okay.
But imaging is absolutely essential in acute head trauma if those red flags we mentioned pop up.
Deteriorating status, severe headache, focal signs?
Exactly. Or a suspicion of a neck injury. In an emergency setting, a CT scan is usually the first choice. It's quick and good for ruling out skull fractures, bleeding inside the head, intracranial hemorrhage, or brain bruises, contusions.
And MRI, when would that be used?
MRI gives much more detailed pictures of the brain tissue itself. It can pick up more subtle structural damage. Specialized sequences like diffusion-weighted imaging are particularly sensitive to the shearing injuries we talked about.
Can it show functional changes too?
Functional MRI, or fMRI, can actually show changes in blood flow patterns in the brain, that cerebrovascular reactivity, especially in the acute phase. And if symptoms are really dragging on, say for more than a month, an MRI might be done later to make sure there isn't some other underlying neurological issue mimicking the concussion symptoms.
Okay, so imaging has a role, but it's more about ruling out other serious problems, not diagnosing the concussion itself.
Precisely. Diagnosis is primarily clinical, based on the history and examination.
Right. Let's talk about treatment then. The old advice used to be just rest, dark room, do nothing. Has that changed?
Oh, massively. Our understanding has really evolved. The initial step is still immediate removal from whatever activity caused the injury or makes symptoms worse. And definitely no same-day return to play or demanding activity.
But not weeks of bed rest.
No, absolutely not. For acute concussions, the current recommendation is actually a very brief period of relative cognitive and physical rest, typically just 24 to 48 hours.
Just 1 or 2 days.
Yes. This is not strict bed rest in a dark room. We now know that prolonged complete rest can actually be detrimental. It can lead to worse outcomes, more anxiety, depression, and even prolong the physical symptoms.
So what does relative rest mean then?
It means minimizing activities that actively provoke or worsen symptoms. So maybe reducing screen time, avoiding noisy environments, not doing strenuous physical exercise right at the start, just taking it easy initially.
And then what?
Then, that short period of initial symptom-limited rest should be followed quite quickly by starting a carefully structured and supervised graduated return to activity protocol. This is fundamental to good recovery.
Ah, yes, the graduated return to play protocol. That sounds key, especially for athletes, but you said the principles apply more broadly.
They do. It's relevant for students returning to school, people returning to demanding jobs. It's a structured, step-by-step approach to systematically reintroduce physical and cognitive challenges.
How does it work? How gradual is it?
Typically, each stage lasts at least 24 hours. So assuming someone stays symptom-free at each step, it usually takes about a week to get through the whole protocol and be cleared for full return to sport.
A week minimum. And why is that stepwise approach so important?
It's vital because it allows the brain time to adapt and heal while gradually increasing the demands placed upon it. It helps prevent symptoms flaring up badly and reduces the risk of getting re-injured by doing too much too soon.
Can you walk us through the stages?
Sure. It usually goes something like this. Stage 1 is symptom-limited activity, basically daily activities that don't provoke symptoms. The aim is rest from demanding tasks, less screen time, quiet environments, maybe live school or work activities if tolerated.
Okay, taking it easy.
Stage 2 is light aerobic exercise. Once they're symptom-free at rest, they can start things like walking, swimming, gentle stationary cycling, keeping the heart rate fairly low, say below 70% of maximum. No resistance training yet. The goal is just to increase heart rate gently without symptoms. This actually helps brain blood flow and recovery.
Right, so activity isn't bad if it's the right kind.
Exactly. Stage 3 is sport-specific exercise. More dynamic movements now, like running drills, skating for hockey players, throwing. Still no head impact activities, though, adding movement and agility back in.
Getting closer to the sport.
Stage 4 is non-contact training drills. More complex training here. Passing drills, team plays, starting some progressive resistance training perhaps, building exercise tolerance, coordination, cognitive load of practice, but still no contact.
Crucially, no contact yet.
Stage 5 is full contact practice. This is the big step before competition. Returning to normal training, including contact drills appropriate for the sport, all done in a controlled practice setting. It's about restoring confidence and checking skills under pressure.
Have fun with
Stage 6 is full return to play. If and only if the individual is completely symptom-free through all those stages and gets clearance from a healthcare professional, then they can return to normal games or competition.
And what if symptoms come back during one of the stages?
That's the key rule. If symptoms return at any stage, you drop back to the last stage where you were completely symptom-free, rest for another 24 hours, and then try progressing again.
So listen to your body. Don't push through symptoms.
Absolutely. This patient-systematic approach is what really minimizes the risk of prolonged problems or getting hurt again.
That's a really clear framework. What about people whose symptoms do persist beyond that acute phase? Someone in the PPCS group, for instance. Are there more specific therapies beyond just gradual activity?
Yes, definitely. When symptoms persist, the approach needs to become much more targeted, and that interprofessional team really comes into play.
What kind of targeted therapies?
Well, medications might be considered for specific symptoms. For persistent headaches, maybe low-dose amitriptyline, which works on nerve pain, or something like propranolol if migraines are a feature.
And for the dizziness or visual problems people often get.
Those are incredibly common and disabling. There are specific screening tools to pinpoint the cause. Is it the inner ear, vestibular system, eye movements, ocular motor, or maybe neck issues contributing?
And based on that?
Based on the findings, you get active therapies. Things like cervical physiotherapy for neck pain and stiffness, specific vision therapy exercises prescribed by an optometrist or therapist to retrain eye tracking, focusing, and coordination, or vestibular rehabilitation exercises from a physio to help with balance and dizziness. These are active treatments, specific exercises, not just passive waiting.
Is there any way to objectively know when someone's brain is ready for more vigorous exercise, especially if they've been struggling with symptom flare-ups?
Yes, there's a useful tool called the Buffalo Concussion Treadmill Test.
How does that work?
It's a graded exercise test,
Yeah.
usually on a treadmill, that helps determine the heart rate at which symptoms start to appear or worsen. It helps figure out a safe threshold for aerobic exercise.
So you find their symptom threat.
Exactly. Then you can prescribe exercise just below that threshold. The goal is to gradually increase their exercise tolerance over time. Once a patient can exercise for about 20 minutes at a target heart rate, symptom-free, for a few days in a row, they're generally considered physiologically recovered enough to handle more activity.
Does that mean they're ready to play sport again?
Not necessarily full contact sport. Physiological recovery doesn't always perfectly align with being ready for the cognitive demands and physical risks of competition. But it's a key milestone. It allows them to get the benefits of safe aerobic exercise, which we know aids overall recovery.
Okay. So pulling this all together beyond the specific exercises or medications, what's the big picture view on managing concussion, especially when symptoms linger and really disrupt someone's life?
The big picture, the absolute necessity, is that interprofessional team approach we mentioned earlier. It's not just helpful, it's essential for truly comprehensive, holistic management.
Remind us who's on that team again?
It can be a wide range, depending on the patient's needs. Neurologists, neuropsychologists, physiotherapists, occupational therapists, speech and language pathologists, sometimes social workers, psychologists, or psychiatrists if mental health is a factor. They all need to work together.
Why is that collaboration so crucial?
Because it ensures all the different aspects of the person's recovery. The physical symptoms, the cognitive difficulties, the emotional impact, the social challenges, returning to work or school, are all addressed at the same time, in a coordinated way. The StatPearl source we looked at really emphasized how much populations like veterans and athletes benefit from this kind of integrated care.
Are there specific programs that use this integrated approach?
Yes, there are. For instance, studies have shown that programs like CogSmart, which combines cognitive rehabilitation training with support for returning to employment, can lead to quick recovery and fewer people developing post-concussion syndrome. This seems particularly helpful for veterans who might also have PTSD alongside the concussion. That integrated care is what makes the difference for long-term outcomes.
So addressing those other conditions like depression or anxiety or PTSD is a really important part of concussion management too. It's not just treating the head injury in isolation.
Exactly that. Treating those comorbidities, the conditions happening alongside the concussion, significantly helps recovery from the concussion symptoms themselves. We know, for example, that getting people into controlled exercise early on helps prevent prolonged symptoms, partly because it reduces depression, anxiety, and sleep problems, which are all so common after concussion.
Exercise as medicine again.
It's a powerful non-drug intervention. And the other absolutely crucial factor, both for preventing prolonged symptoms and for successful treatment, is patient and family education.
What kind of education?
Setting realistic expectations is huge, explaining that symptoms are often worse in the first week or two, but usually do improve. Busting myths, like the idea you need to lie in a dark room for weeks we know now that can be harmful.
Empowering them with knowledge.
Precisely. Giving patients and their families accurate information, strategies they can use themselves, and confidence that recovery is possible. It shifts them from being passive sufferers to active participants in their own healing journey. That proactive mindset is key.
Okay, so let's try and synthesize all of this. Thinking back to the Ontario study and everything else we've discussed, what are the main takeaways? What does this evolving landscape really mean for us?
Well, it certainly brings us back to those surprising findings from the Ontario study. That direct comparison between the acute and PPCS groups really did throw up some counterintuitive results, didn't it?
The ones about the traditional risk factor.
Yes. The fact that sex, a history of mental health issues, and a history of headaches or migraines didn't show up as significantly more prevalent in the PPCS group compared to the acute group, especially when you think about that commonly quoted 10–20% progression rate.
It challenges that idea, doesn't it? That only a small specific group with those factors is destined for long-term problems.
It really does. It suggests the baseline vulnerability might be much broader, more similar across many people who get a concussion, regardless of those specific pre-existing conditions. That fundamentally changes how we should think about identifying who's at risk.
So we can't just tick those boxes, female, history of anxiety, history of migraines, and say, high risk.
It seems not, based on this direct comparison. It really forces us to reevaluate how we identify people who might struggle. It suggests it's probably a much more complex interplay of factors rather than just a few simple predictors telling the whole story.
But some factors did clearly stand out in the study as differentiating the groups.
Yes, absolutely. Age was significant. Patients over 40 were at substantially higher odds of having prolonged symptoms. And the mechanism of injury, those transportation-related incidents carrying much higher odds, those are things we really need to pay close attention to right from the initial assessment.
And the geographical finding.
That finding about higher odds for PPCS outside the major metropolitan center, that really points towards potential access to care disparities. That needs looking at from a healthcare system perspective. It's not just about the individual patient. It's about the system they're navigating.
Right. This deep dive has definitely painted a more complex, more nuanced picture of concussion than just a bump on the head. And it leaves us with a really important, maybe even provocative question for you, our listener, to think about. If that commonly cited figure, that only 10–20% of people develop persistent post-concussion symptoms, is actually, as some research hints, a significant underestimate, maybe closer to 50% in some real-world settings. What does that really mean? What are the implications for our healthcare systems, for our communities, for how we understand brain injury?
It suggests a much larger burden than perhaps we've acknowledged.
Exactly. This deep dive suggests many more people might be struggling with prolonged recovery, often without having those classic risk factors we used to focus on. So what more do we need to uncover about this sort of unseen burden? And how should this evolving understanding shape how we prevent, diagnose, and support the millions affected?
It really pushes us towards thinking more holistically, doesn't it? Beyond single factors, towards more integrated care models that are accessible to everyone.
Absolutely. Well, we really hope this deep dive has given you a fresh perspective and some valuable insights into the complex world of concussions and prolonged post-concussion symptoms.
Hopefully some useful takeaways.
If you did find this discussion illuminating, we'd be grateful if you could take a moment to rate and share this deep dive with your colleagues or anyone in your network who might benefit from these critical insights.
Thanks for joining us.
Thank you for joining us on the Deep Dive.